start. It's now 9 o'clock in Melbourne, Australia, and 5 p.m. in Calgary, Canada, and 7 p.m. in wherever Patty is. I apologise, Patty. I thought you were in Calgary. So I'm Carmen Leif-Jenkins, Managing Editor of the International Journal of Stroke and Project Manager for the World Stroke Academy. If you're on Twitter, our hashtags are at World Stroke Org and @JStroke. So this session runs for an hour and will be recorded and hosted on the World Stroke Organisation website and our YouTube channel, which is currently running live there at the moment. After this brief presentation from this excellent group of researchers and clinicians, we will have a Q&A hosted by Professor Julie Bernhardt. If you want to add to the Q&A, please do so using the Q&A function, which you'll be able to see on the bottom of your screen for most people, and not the chat function. Please do ask questions during the talk, rather all at once in the end. That'll make things a little bit easier as we're running. So we'll start today with Professor Chris Bladin and the topic, how we established an effective acute stroke telemedicine program in Australia. Professor Chris Bladin is from the University of Melbourne and is a practicing neurologist who's worked in London, UK, Toronto, Canada, and has NHMRC funding in stroke research, and he has a special interest in stroke thrombolysis, acute stroke, brain imaging and stroke telemedicine, and is a director of stroke at the Victorian Stroke Telemedicine Service in Ambulance Victoria. Chris, go for it.
Thank you very much, Carmen. I'm going to now start the screen share and hopefully we can get this organised. Okay. Allow Zoom, just bear with me for 2 seconds while we get that set up. Record the content. Okay, quit now. Right. I'm just trying to get the Zoom screen sharing happening here, which is proving a little bit of a struggle. I do apologize. Just bear with me. I've got the presentation opening. You are the host now. Let's try. Desktop, that's one, share, got it. Okay, now we're in business. Okay, can everyone see my screen? Hopefully you can. So I'm just going to now talk you through how we established an acute stroke telemedicine service in Victoria, Australia. Okay, so firstly, let's talk about what the Victorian Stroke Telemedicine Service is. And this is a service that involves 17 Victorian hospitals and now more recently 2 hospitals in Tasmania. It allows 24/7 access to neurologists, stroke specialists, irrespective of the location. And we provide treatment advice about patients presenting to the emergency department with suspected acute stroke. And that's a really important element to this because patients don't come to hospital with stroke, they come to hospital with suspected acute stroke. So we have to be prepared for that capability as well. So we rely on audiovisual communication between the neurologist and the stroke specialist and the ED and the patients and carers, of course, using real-time brain imaging. And on the right-hand side of your screen, you can see the equipment that we are using. This is a bit of equipment developed by Maytech, a German company. And the most important part of this telemedicine equipment, or the teledoc as it's known, is in the bottom right-hand corner of the screen of the teledoc. You can hopefully see a green button. And basically, once the teledoc is rolled out to the foot of the bed, all the staff need to do is push the green button and we will appear on the screen. And the service is available 24/7. So these are the hospitals that the VST is currently running at. It's 17 hospitals in Victoria, as you can see, and 2 hospitals in the northwest region of Tasmania. Now, the VST commenced in 2013, and it's now active in all 19 hospitals. And importantly, in Victoria, we've done some mapping and we've determined that 95% of the population of Victoria are at least within a 1-hour drive time to a TPA service. added to that, we have a statewide thrombectomy protocol that relies on a 1300 number. So we give absolute priority to patients who need to be transferred from the remote centres into Metro Melbourne for endovascular clot retrieval. Okay, so just quickly talking through the process that we use for our telemedicine service. And as you can see here, patients present with suspected acute stroke. Hopefully they dial 000, or for those perhaps overseas, 999, and they contact the paramedic service. They're brought into a VST hospital. It's followed by rapid triage and assessment, and all patients then go off and have a standard brain imaging protocol consisting of a plain CT scan of the brain, a CT angiogram, and a CT perfusion study. And all our sites now do CTA and CTP. Even the very, very small regional hospitals can now do that CT protocol. The 1300 number, VST 1300 number is called, and that takes you directly through to a roster of stroke specialists who will take the call, take some clinical details, and then we'll set up a video consultation and look at the brain imaging. And we in particular have a conversation with the patient and family and the treating clinicians. And the important part about that is that that's not so much talking about stroke, that's actually making a differential diagnosis. Because again, to highlight, patients come in to hospital with suspected stroke, and we know that about 40% of those cases of suspected stroke in fact turn out to be something else. And sometimes it's something completely different, and sometimes it is actually a neurological problem, and we can also provide advice on things like seizures, on brain tumours. Sometimes it's something more simple, just like a syncope, fainting, that we can also provide advice for. Now, if in fact they do have a stroke, then we can determine the best stroke therapy, and that may be stroke thrombolysis, or it may be transferred to one of the Metro Melbourne hospitals for endovascular clot retrieval, and that could be via helicopter, fixed wing plane, or obviously by road car. So one of the things we've really looked at pushing inside VST is making sure there's rapid access to brain imaging, and we've set up partnered with a company called ProMedicus, who are in fact an Australian company, but they now have a very large footprint in North America, and they've expanded into the Mayo hospitals, Harvard hospitals, and the Duke University hospitals as well. They've got a very big international footprint. And what's very unique about their service is that they have true thin client software, and they've sort of got a merging of PACS with Netflix. And the reason I've put that up is that what happens is that the images get pushed to a central server, and we can then play with the images and manipulate them on that central server. And then basically, like Netflix, we can stream the results of that manipulation to our computer. So rather than having to shift a whole image file across and play with it on our computers themselves, we can actually do that all centrally. And so the Visage software has been incredibly helpful, allowing for rapid downloads and really quite extensive manipulation of the images that we're able to get. Okay, let's move it on. So the images we get are pretty similar to this, and as you can see here, we have a lot of tools that we can play with to manipulate the images. We get CTA and CTP on all images, and obviously you can see in this particular case we have a patient with a left middle cerebral artery M1 occlusion and a large perfusion deficit. And as with all this, the CTP parameters, we can measure mismatch and volume of infarction, etc. And that's now functional across all our sites. So just quickly to go through some of the metrics, we're doing about 3,000 consults a year. The top blue line you can see is the total number of consults, initial consults that are coming through. The red line is the number of ischemic strokes, and you can see there that around 40% of our consultations are in fact ischemic strokes. of the ischemic strokes that come through. The green line is the number recommended for TPA, and the purple line number recommended for clot retrieval. And we're treating about 20% of our ischemic strokes with TPA, and about 12% of our ischemic strokes are being transferred in for endovascular clot retrieval for thrombectomy. So just quickly to go through some of the new directions that we've now taken with VST. We have now moved to a tenecteplase only thrombolysis thrombectomy service, and we initiated that just a few weeks ago, and that's already gone quite well. That was initiated after quite extensive discussion amongst all the clinicians and various hospitals, and there was really overwhelming support for that, given that it's simpler to use, certainly less expensive, and with equivalence, we feel, in the delivery or the capability of thrombolysis. The other thing we've recently we're just about to initiate is a priority transfer service for intracerebral hemorrhage, and we've developed a new 1300 number protocol for that, with one of our metro hospitals prioritising taking those patients into their neurosurgical and stroke services, so that rather than just focusing on treating ischemic stroke, we now have a clear, streamlined pathway for treatment of intracerebral hemorrhage that occurs in all the regional hospitals. The other element to the service, we feel, is to complement the acute service, telestroke service that we're delivering, with a early intervention into neurorehab. The guidelines tell us that a neurorehab consult should take place within 48 hours of admission to hospital. So we've now started to initiate an early tele-neurorehab assessment that we're hoping to roll out across the rest of our service over the next year or so. And we've also started looking at teleparamedicine, and there's been a lot of work coming out of particularly New York City about teleconsults done in the back of the ambulance, particularly in the context of COVID and wanting to assess these patients better while they're outside the hospital. So we're now starting to explore a teleparamedicine service, and we have some digital software that we can use to initiate that, and it really does push us towards commencing stroke care out in the community, and that's what we're really about, getting stroke care starting at the bedside, not just at the time the patient arrives inside the emergency department. So I've gone through that reasonably quickly to allow time for all our other speakers, of course, and for any questions that do come up. And of course, teamwork is a key to achieving our successes. Thank you very much indeed.
All right, great. Thank you so much, Chris. Please, everyone, don't forget to add your questions to the Q&A function during the talk. That's happening, and it's great to see, but we'd love the questions in the Q&A section. Just a reminder, this webinar is hosted by the World Stroke Organisation and the Canadian Stroke Consortium, our good friends and colleagues there. If you'd like to follow them on Twitter, they're at CSC_stroke. All right, now we're going to move on to Professor Dominique Cadilhac from Monash University, and the topic, Community of Practice for Telehealth in the Post-acute Stroke Phase. Professor Cadilhac is an expert in health services research within the field of stroke, with an application of her work in acute rehabilitation and long-term care. She's published over 220 articles and has a clinical background in nursing. She currently heads a translational public health and evaluation research division in stroke and aging research within the School of Clinical Sciences at Monash University, and is the head of public health stroke division within the Florey Institute of Neuroscience and Mental Health. She's also the data custodian for the Australian Stroke Clinical Registry, OSCAR, and co-led the Victorian Stroke Telemedicine program. Her skill set includes epidemiology, implementation science, telehealth, and economic evaluation. Dom, take it away.
Thank you, Carmen, and thank you for the opportunity to talk about a new initiative that we've started within the Australian setting, but is open to all. And we're bringing together this community of practice for telehealth in stroke that's beyond the acute phase. And with COVID-19, we had to really ramp up what we were doing, because there was an immediate outcry for switching in-person clinical consultations for rehabilitation or other follow-up into a more telehealth model or non-face-to-face program. So I'm presenting where we're up to with this community of practice and what we've achieved so far, and also how others from the World Stroke Academy or World Stroke Association organisation may get involved. So now I'm going to work out why I can't. Is that switching over? Yeah. All right, so the overview, it's really a forum for clinicians and researchers working in stroke, rehabilitation, recovery and long-term management to get together to provide support to one another, share resources, build skills, build expertise. We provide a secure communication channel for collaboration, and we really look towards also providing mentorship by people who already have good experience in conducting either research programs in this space or delivering clinical services in this space. And what we're hoping is that we will end up with a suite of training tools that can support the field. We have terms of reference for this group, and the scope are really clinicians and researchers working in stroke recovery and management interested in integrating telehealth into their clinical practice or research. We have a communication board that at the moment is being hosted through Microsoft Teams, because that's a very accessible platform for everyone. And we've been running a couple of meetings, and in fact our second introductory meeting will be today, and we will be holding these bi-monthly or as required. And for those video conferences, we're using the same platform as today, which is Zoom. And the main principles and expectations of when we come together is that it's inclusive, it's respectful, that we maintain confidentiality, especially for things that may not be in the public domain yet, and that there's open sharing and collaboration. And it is important for me to highlight that this has come together through my work with the Centre for Research Excellence in Stroke Recovery and Rehabilitation, that is headed up by Julie Bernhardt and Michael Nielsen, and Coralie English and myself are both co-chairing this initiative. So the way we've set it up is that we have myself and Coralie as co-chairs. We have a core project group that are assisting us with a lot of the background work that needs to happen to make this successful. We then have established an advisory committee that is interdisciplinary, and we have representation from different jurisdictions. But importantly, because the scope is so broad, we've set up various interest groups and have looked to seek for leaders of those groups to run and develop programs that can be shared back to the broader group. And then we have our overall membership. So at the moment, we're really pleased to say that even though we've hit the ground running in a very short space of time, we've managed to have 382 members signed up. And 85% of those do come from Australia, but you can see we do have good representation growing from other countries, and we're very much appreciative of other countries that have done a lot of work in this space that are willing to share with us their expertise or their guidelines for how they establish their programs. We've set up 5 interest groups that are focused on clinical aspects, but we will also have a research group that will help support research initiatives around this community of practice. So you can see we have communication and swallowing problems, neuropsychology, memory and cognition as a bundle, physical and sensory functioning as a bundle, secondary prevention and medical support, and then we have general telehealth, quality assurance and billing, because these are the types of issues that come up, and we're not just looking at these in silos, but the information between these aspects will then be able to be shared. Another initiative is that we've paired up with the Stroke Foundation. In fact, this is one of the first things that was done and was initiated with Coralie liaising with the Stroke Foundation. We have a platform for clinicians to access resources for stroke, including our national clinical guidelines, and all of the resources that we've identified that we feel are appropriate and can be shared with the community of practice or others who have an interest in this space can be accessed via the Inform Me webpage on the Stroke Foundation website. So the other important thing, or the last thing that I kind of wanted to raise, was future considerations and the need to have standardised minimum data. So this is one of the things that we've established for acute telestroke as part of an internationally agreed minimum data set. So that was published early this year. And what we would like to see is that within this space, we can also collect or have minimum data collection variables agreed, so that we can do some reliable international comparisons. We can look at ensuring quality as well as benchmarking, and permit some real world comparative effectiveness evaluations. So if you want to get involved, there's some information there on how to register through the MailChimp. So this just requires you to provide us your email contact, so then we can send you out information. Or we have other ways in which you can participate. So you can contact us via this email at Flory. Thank you very much.
Thank you so much, Dom. That was fantastic. So please, everyone, don't forget to add your questions to the Q&A function during the talk. We're getting quite a lot of questions, which is really great. If we don't get all through those, we can also continue in a tweet chat in a week or so, which we could organise. We'll now move to Professor Mike Hill from the University of Calgary, who'll give us a brief overview of telehealth for remote stroke management in Canada. So he's given me a funny bio because he's got a great sense of humour. So he's a stroke doctor and clinical trialist from Calgary, hockey player. I have had COVID-19, am all better without any scars, and now have a COVID beard. Professor Hill is also Professor for the Departments of Clinical Neuroscience, Community Health Sciences, Medicine and Radiology at the University of Calgary, and is also the Director of the Stroke Unit for the Calgary Stroke Program, Alberta Health Services, and is currently Director of Stroke Unit at Foothills Medical Centre, Calgary Health Region. Thanks, Mike. Take it away.
Thanks, Carmen. Can you just confirm that you can hear me and see my screen?
Confirmed.
Great. Okay, so here we go. So I just made a few slides. So and actually this follows on really nicely from what Chris and Dominique have just said, because you know, I thought I would just talk about a lot about how we've adapted our telemedicine system and accelerated it really in the setting of the COVID-19 pandemic. Because of course, as everyone on the call will know, and almost certainly has experienced, the evolution to technology-based assessments has been really critical. So I'm going to talk about acute stroke, subacute stuff. One interesting adaptation we've used, which is the stroke unit peer support, some outpatient stuff, and then early supported discharge. And I'm going to do it all in 3 slides. So I'll just show you some stuff. So the first thing is that our systems are governed by province. So in the same way that in Australia, the systems will be set up by state, most of the telemedicine systems vary by province with setup, and you'll have exactly the same kind of network that Chris described, with a number of peripheral hospitals and then access to a consultant or a consultant system at the tertiary center. In this case, this is just this is like a TV robot person helping to interview a patient. I actually find that personally in acute stroke, before COVID-19 and even during COVID-19, the same, that the dominant thing that helps us to make decisions about what to do with patients is imaging. And so it's certainly in Alberta, and it's true in Ontario and many of the other provinces as well, that there's essentially a single PAC system. Again, Chris, you described the same system in the state of Victoria with links to the Tasmanian centers as well. Where you can look at imaging and understand what's happening in the brain. So a patient comes into hospital, quick assessment, notification of us, they go straight to imaging, and then we look at the imaging and often just over the phone. There are certain circumstances where the video consultation with a patient is helpful, but I would say 90% plus of the time you can make the decision in discussion with whoever the attending emergency physician is, or family doc or internist, etc., and help them make a decision about what to do. In the setting of a patient who needs to come for endovascular thrombectomy, or in Australia, ECR, clot retrieval, same principle, then you're getting the patient to us. In Canada, where our situations are dominated by long distance, so we do make use of air ambulance. This is a picture of the STARS Air Ambulance, which services 3 of the Western provinces in Canada. And they've been terrific at getting us patients quickly straight to, in my case, at Foothills Hospital in Calgary. So we would evaluate the patient with the team at the primary hospital, and then get them in often by helicopter directly to Foothills Hospital. And obviously we're hoping for this scenario. Here's a picture of a couple of my colleagues, Maya Goyal and Mohammed, and the endovascular team, and the patients giving a thumbs up as they're on the weak left side, which is now better after successful thrombectomy. So obviously part of the process is to get people in quickly, and that's what you're trying to do. So our approach has been, you know, heavily weighted towards just looking at imaging and talking to patients. We do have a setup where we can see the patients and provide a consultation. But overall, my experience is that the decisions need to be made quickly, and looking at imaging and talking to the attending doc is all you need. Now, in the subacute setting and on a stroke unit, sometimes we get called and we're asked to provide, you know, advice on what to do with this patient day 2 and they're at a primary hospital, or day 3 and something's happened that we want to know. Same principles have actually applied. We have a common PAC system in Alberta as an example province, and it's true elsewhere in the country as well, where you can then look at the imaging and discuss with the attending physician or team what to do. I have used the patient video, so like the robot thing where you're moving the video camera to where the patient is, and that's been helpful. But again, I would say it's uncommon that it actually substantially makes a difference to the patient outcomes. It's certainly been useful in the setting of COVID-19 because you're always managing stuff remote. Now, one interesting thing that's happened recently in our place, so obviously we've been sort of locked down for about 6 weeks or so, a bit more than that, and almost 8 weeks now in terms of patients. And so we actually have a group of peer supporters, often patients who've had stroke recovered, who come back to provide peer support to our patients while they're on the stroke unit or on the rehab unit. And of course, they've been disallowed from doing that in the same way that we've not had visitors in the hospitals to try to reduce any possible transmission. And so we've instituted a system where we're using essentially technology, so tablet-based interactions, so that the peer supporters, in combination with the bedside nurse, can then actually talk to the patient and provide that kind of peer support. And it's just started, but it's honestly an inventive way from our peer support team to provide that for the patients. I know that our patients in the pre-COVID setting were really, really appreciative of having peer supporters come up and talk to them. I think that's been helpful. So this is a novel way that we're again using technology or a telemedicine approach to helping. The final thing I'll talk about is stroke outpatients, and many of our clinics have reverted to this, working at interactions on the outpatients. And here's a picture of Khurshid Khan, who works in Edmonton, north of me, so 300 kilometers north, but working on a clinic-based outpatient visit. And we actually do this routinely throughout Alberta, particularly in Edmonton, where there's more northern communities, in which you can provide this kind of outreach, and it's very, very helpful. I've done it with some of our, and we have done it with some of our more southern communities in the south part of Alberta. But you can run a clinic, you can talk to people and get them sorted out. The trouble is, I don't really have a sense of numbers, but my guess is about, 20%, maybe a quarter of people, you really lose out not being able to examine them and understand what's happening to them neurologically. However, for simple things like follow-ups and sorting out what to do with certain medication, or giving somebody feedback about what their MRI shows, for example, telephone or telemedicine visits have been absolutely terrific. Patients love them. They don't have to come and find parking in the hospital and that kind of thing. So for simple things, we've been using this process for some time. It's adapted extremely well to the COVID-19 situation, where we've been interacting with patients and managing where we can. And lastly, we've also been using it for early supported discharge. So our early supported discharge program, again, same idea, getting patients out of the hospital earlier, with the therapy teams actually visiting the patients in their homes. That's been disallowed because of COVID-19, so we've been trying to do it remotely using the same systems. I think there are some significant limitations in terms of hands-on types of therapy, which obviously can't be done, but there's still the opportunity to interact, to teach, and I think at least as an interim measure, it's been good. It may well be something that we can extend to future in the setting where patients don't actually need the direct hands-on contact. So I'll stop there, Carmen. Thanks very much, everybody, and we'll welcome any questions as they come through.
Great, thank you so much, Mike. Please, everyone, don't forget to add your questions to the Q&A function during the talk, and if we don't get to your questions, we may be able to run a tweet chat a little bit later in the next week or so. Just a reminder that this webinar is hosted by the World Stroke Organisation and the Canadian Stroke Consortium, and you'll be able to access a recording of this webinar afterwards on either of those websites for both those organisations. So we'll now move on to Patrice Lindsay, who is covering the topic Telestroke Best Practice Guidelines. Dr. Patrice Lindsay is currently the Director of Systems Change and Stroke Program at the Heart and Stroke Foundation Canada. She leads strategic directions for systems change and knowledge translation across Canada, and is a senior editor for the Canadian Stroke Best Practice Guidelines and leading author of the World Stroke Organisation Global Stroke Guidelines and Roadmap. Go ahead, Patty.
Thank you, Carmen, and thank you, everybody. I'm actually sitting in Toronto, Canada, so I'm a little bit later in the evening than Michael is. So we've had some really interesting things change in our healthcare system on a very rapid pace over the last 12 weeks. And some of our realities are that where we used to do telestroke mainly in the acute stroke management phase, we're suddenly having to do telestroke or virtual healthcare across the entire continuum. So I'm going to talk a little bit about what that reality really means, what we know about guidelines or what we have in guidelines, and a little bit about implementation. Now, the interesting thing, and to pick up on what both Dominique and Michael have talked about, a recent survey in Canada showed that 63% of Canadians would like to be able to use email, but only 24% of family physicians were using it. And 41% would like to have video visits, but only 4% of family physicians were offering this service. You know, fast forward to 2020, and our Canadian Medical Association has urged everybody to start scaling up and providing virtual care because they have no choice. When we look at providing care versus what is the evidence to help shape that care and inform the way that care should look, we have a real mismatch. So in stroke, we talk about, you know, mismatches in terms of core and penumbra. We also have a mismatch in terms of practice and evidence when it comes to telestroke and telemedicine for stroke care. So the earliest telestroke showed up around, you know, just after TPA first came out, so late 1990s, early 2000s. Since then, we really saw most of the expansion of telestroke in the acute care setting for hyperacute administration of alteplase. Around kind of the last 5 or 6 years, we started to see more guidelines show up in telerehab. And very, very little is out there in terms of evidence or guidelines when it comes to prevention clinics or ambulatory services. But as I said, in 2020, we're doing it across the board. So Paul Webster, in a recent publication in The Lancet, really poses the challenges. The real question is whether these measures will stay in place after the pandemic. And I think for telemedicine, it's probably one of the only and few positive unintended consequences of the COVID pandemic was a real fast forward for something we've been fighting for years and not being able to move. The challenge is we have very few guidelines and even less evidence guiding us beyond the acute phase. So the evidence for using telestroke and proving that it's, you know, as effective as in person when you're in, you know, somebody like Mike or Chris remoting out to one of the smaller communities with the right people and processes in place, it has proven to be as good as. It's certainly not inferior with a good setup system. As we get into rehabilitation and prevention, the guidelines mention it, they talk a little bit about it, but there really is very little evidence until more recently. In the last 2 years, we've started to see a little bit more emerge. So then how do we develop guidelines in the absence of evidence? When we've looked at all the guidelines currently existing and looking at, we've spent a huge amount of time on this in the last 6 weeks. I've spent quite a bit of time. There's some issues that have to be dealt with within the guidelines and core concepts. So first of all is capacity and ability. Now that is both in terms of the person providing care, so the clinician. Do they have the training? Do they have the knowledge? Do they know what their legal responsibilities are within their college, their professional college and licensing? The ability also applies to our patients. When you think about stroke patients, they may have physical disabilities, cognitive disabilities, which may inhibit their ability to use technology effectively and actively and safely participate in care through virtual setup. So that has to be addressed. The other interesting thing, because I've been working with a group of patients on developing some tools, which I'll share in a few minutes, is the privacy. So we all are quite aware of, privacy when it comes to personal health information. A lot of the guidelines talk about the technology and what kind of, special encryption you need to have to protect patient privacy. A lot of that seems to have gone out the window because there was such a rapid increase. Now, Zoom and other programs have created now medical grade privacy on their sites, but that's not available to everyone. The other interesting piece that's come out of this when looking at setting up guidelines is patient privacy. I've had several patients tell me in the last few weeks they're not about to open their shirt and flash for a physician on screen or to get a little too personal on the camera. They're very worried about their security and self-consciousness. So we really need to think about that. So access to imaging, that's a core piece in all guidelines. That's the most consistent piece in terms of what are the guidelines for telemedicine, is access to remote access to all the imaging, your CT scans, and very quickly with a quick push from the referring site to the consulting site and without delays because time is brain, as we know. The other pieces are looking at assessments and therapies, especially when you get outside of acute care. What kind of rehab assessments or prevention assessments can we do virtually? You can do an NIH virtually. There is a MOCA available that is validated in virtual. The Chinook McMaster is validated for virtual use, but a lot of other tools we don't know, and we don't know how to use those. So there's real push now to start getting validation of our common stroke tools and to be able to incorporate those effectively in guidelines. The other core component is documentation. It's great to do a virtual visit, but you have to document it. And we found there has been real gaps when you kind of sign off because you're not in your normal routine. So there has to be processes in your guidelines talking about the need for documentation and follow-up. The other tricky part when you're doing remote care we've now started to address in the guidelines is team care. Stroke is a team sport. It is not an isolated sport, especially in acute, but in rehab and prevention, there's often multiple, the multidisciplinary team members working with the patient. So how do you communicate what you've done and what you've talked about with the other team members who may have separate visits? The really cool thing is with some of our technology, you can have multiple team members working with the patient all at the same time. So really have to think about that and build that in. And then the timeliness, and then the technology, which I've already spoken about. So we've had clinical guidelines. These are most recent, were 2017. Surprisingly, when you look at that list I showed earlier, there's very little current recommendations on Telestroke. Now, we've just done a quick update. There has been, as I talked about, Bob Teasel and the group in Canada just recently did a series of 6 telerehab research projects and have combined them into a report that talks about the evidence and gives us some of the evidence. In Canada, as well as many other countries, there's been rapid development of guidelines for stroke overall within the year of COVID. Very few of those guidelines have actually talked about virtual care. Our guidelines had 3 major statements just emphasizing the need to incorporate it, to use it with protocols and to the best of your ability, and to remove some of the barriers, which I addressed earlier. So I'm not going to read the details of the different guidelines, but there are some for acute. They are the oldest, most long-standing, and the strongest evidence. You see A and B level evidence. When you get into rehab and look at some of these other areas such as consultations and rehab, you're looking at C-level evidence and lower levels. So I really urge our researchers to help us build that gap. What we've done is taken all of that evidence and just last week released a new toolkit that goes to support virtual healthcare and stroke. We've looked at it looking at emergency care, secondary prevention, rehab, and also education of patients. That is one of the areas that we really emphasize in our guidelines because it's one that we find is really poorly done within a virtual setting compared to in person. If they're coming to a clinic, they'll see the physician, then they have the nurse or other person providing additional education. That's not happening on a lot of virtual visits, and that's become a real gap that our guidelines are trying to address. So within our toolkit, we've looked at governance, how you have to set up your programs, technology, clinical readiness, and then actual care delivery. And for each of these sections, we've created a checklist, both for physicians and also for patients, so that you can know exactly what you need to have prepared and how to deliver, and so that the patient is also prepared. We have tips that we built from the guideline on effective consultations, so some high-level things to think about before you get into the actual details of each phase of the recommendations. And we've also done that for patients and their families. So we highly recommend that people look at those and use them. They're available on our strokebestpractices.ca in our resource section. And then you can reach out to me at any time. So our summary is we need more evidence. So as everyone's pivoting to virtual care, that evidence is important when you go back to my first quote from Webster about sustainability. We won't be able to sustain our telemedicine without proving its value. So Dominic, who's a very big researcher in this area, please work with your teams to get us the evidence we need to prove the importance of sustainability in this area. So I'll stop there, Carmen. Thank you.
Fantastic, Patty. Thank you so very much for that excellent presentation. All of our fantastic panelists. We've had Chris Bladin, we've had Mike Hill, Patty Lindsay, and Dominique Cadilhac from esteemed research spaces all around the world. Thank you so much, everyone, for being involved. This has been a co-publication of the World Stroke Organisation and the Canadian Stroke Consortium. I'm now going to hand it over to Professor Julie Bernhardt, who'll run the Q&A session now with our panelists. You won't hear from me again, but thank you very much, everyone, for coming along. So, Patty, if you'd like to close your screen, and Julie, I'll pass it over to you.
Thank you very much. A remarkable showcase, I think, of activity in this space, some very new, and Patty, that's so impressive to get that out so quickly. And I fully endorse all of your key points there. And then also with Mike, as we wait for you and Chris to come back on to go through some of the questions. So I'm going to, the first question I'm going to ask is around people's concerns about coming into hospital when they have a suspected stroke. This question has come from Karen Rice, and whether you know of any groups who are trying to set up some kind of pre-hospital system of consultation around stroke. So that would be to Mike or Chris.
So I'll jump in, Julie. I mean, I think it's a key issue that I think a lot of people have worried about. That one of the indirect effects of COVID-19 has been that people are not seeking help, whereas they would have done, 2 months ago or 3 months ago for a TIA or a minor stroke, particularly. I think, anecdotally in Calgary, I can tell you that our number of major strokes is probably about the same. We're treating the same number with thrombolysis and with endovascular intervention. But the number of minor strokes and TIAs being referred to the clinic, coming to the emergency room, being assessed has just dropped off a cliff. And I certainly worry that many of the major strokes we're seeing could have been prevented if we'd seen those people a few days before or a week before. I think that's a worry. There are some data to support that. I've seen some data from Germany which suggests that this is a big issue, that people's behavior has changed, and the public needs to know that we're still here to help them, and I think that's one of the public messages has been this issue. Now, we have not taken the step that you described, which is, could we implement some kind of community-based system, either using some kind of telehealth system where people could just contact us directly. But I think it's it's potentially a brilliant idea to, at least in the short term, to get people back to getting their minor symptoms assessed.
Yeah, and I'll just complement that, saying we've also noticed a downturn in our acute stroke presentations in Metro, but interestingly, it hasn't changed for our regional hospitals. Our numbers are still up there, and in fact, we've noticed over the last month or so, in fact, our thrombectomy and thrombolysis rates have gone up just a little bit. So it's quite interesting, whether it's just a Metro thing or whether it's impacting on regional. We certainly haven't kind of seen that in VST. As I highlighted, we have started looking at some teleparamedicine for very early assessment of patients outside the hospital. One of our hospitals in regional Victoria has started doing that for COVID patients or suspected COVID patients. And I think that's certainly an exciting new direction that we will probably be taking with acute stroke care. And as I highlighted, I mean, it's going to start at the bedside, and I think that's where we're going to try and have that early impact.
I'd like to jump in on that as well, if I can.
Sure, Patty.
So scary. In the last 9 weeks, I've fielded at least a dozen emails that have come into Heart and Stroke saying, I've been having this weakness, or I've been having this issue, but I don't want to go to the hospital. What do you think I should do? And so as soon as those get to my attention, I pick up the phone and call the person and say, call 911 or go to the hospital now. So we've been doing a lot of coaching, and people in those emails to us are saying, I try to get a hold of my family doctor. I can't get an virtual appointment with them for 3 days. Should I be worried? So we've been doing a major public campaign on social media and with earned media to try to promote stroke is still a medical emergency, even in COVID, and please don't ignore your symptoms. But,
absolutely.
It's a real concern. And if they're emailing us, and if I don't see that email for 3 or 4 hours, we're very concerned.
Yeah, absolutely. It's a very important message, and one that I think we all need to promote to our populations. There have been a number of questions. Some of them have been answered as we've been going along. So I'm just going to pick up on one and bundle it. And again, I'm going to focus this to the acute end, and then I'm going to turn to rehabilitation and recovery. So some of the questions around the organisation of the service, who are the people that really are monitoring the service, or actually the workforce behind the telemedicine service for acute treatments. And I also want both you, I'll turn to you, Mike, first. I want you to also consider the question that's come from low middle income countries about alternate systems, because of course you both showed quite sophisticated technologies in place for your model. And there's questions around, could you use WhatsApp? What are the considerations there? So if I can turn to you, Mike, and then get a comment from you, Chris.
Yeah, well, thanks, Julie. So it's a great question. I'll start with the second component first, if you don't mind. I think that it's interesting what's happened with COVID-19 is that the problem with these commercial apps started with FaceTime, but then of course WhatsApp and all of the other ones is the privacy concern, right? Which is patient privacy going to be compromised if you use a public network? And one interesting thing that's happened with COVID-19 is that it's funny how all of those privacy concerns have all been swept away in about 8 weeks, and all of these amazing technologies have suddenly become available when the need is there. So I really hope that one of the things that this pandemic has shown us, and to be optimistic, is that we can in fact use these other systems quite effectively. And I can't see a particular reason why they wouldn't. Now, there may well be privacy concerns, and we're going to have to think about what the degree to which those might be preventative in using a common system like this. But honestly, I've seen so many things melt away that have been problems for 5 or 10 years because somebody put their heels in and said, no, that's a privacy problem, and this is against this rule or this law, and all of a sudden those things have all been swept away, which has been wonderful to see. So I've seen that at multiple levels, and I hope that we would get a chance to do simple things like this. I mean, I know anecdotally, you know, when we're dealing with the you know, the house staff or other people, or somebody's in a place, they just turn on their phone and say, talk to the patient, and we do. And so, you know, like, we're all very pragmatic, and I don't see why we wouldn't potentially get into something like that. So we'll have to see, but I hope that this is one of the things we've learned from the pandemic. Maybe I'll turn it over to Chris and get his thoughts as well.
Yeah, thanks, Mike. Look, I would certainly agree that a lot of issues around privacy have been raised, but they have kind of disappeared in the context of the absolute need for communication and the absolute need to maintain social distancing, and that's both for the patient's protection, but also particularly for the healthcare workers. So anything that can improve communication, I think, has been latched onto and utilised as best we can. I guess the other element to this is that a lot of these apps now are not just simple type and you know, send text and communicate. You can actually do a video component to it. And the interesting thing that we have found is, and it was really interesting listening to you, Mike, talking about this, is the use of video in the console, right? So when I work in my metro hospital, I have these amazing staff at my fingertips, and they go down and they assess patients, and they call me up, and I'm able to give my instant response and say, yeah, look, yeah, thrombolyze the patient, the imaging looks good, or it sounds great, yeah, that's not a problem. What we often tell our telestroke consultants is that when you work in effectively working in a really small regional hospital, you have to shed your metro skin, and you really have to sort of go back to basics, because in these hospitals, the staff are often very inexperienced. They're often rotating. The junior staff, they're rotating every few weeks, right? And they really value the video element to the consults. And we do a lot of site visits to our VST hospitals each year, and the feedback we get absolutely consistently is that we really love seeing the neurologist at the foot of the bed. So the video element is really very much appreciated by the hospital, added to which I have to say that it's not uncommon that we'll do a video consult and we'll actually get new clinical information where we're able to directly talk to the patient. And just occasionally, because I've been able to use the pan and zoom on the camera, I'm looking at the monitor sitting behind the patient, and that atrial fibrillation that has not been mentioned at all is suddenly very apparent behind this. So we find you get new clinical information available to us. So we have a goal of trying to do about 70% of our consults as video consults. And look, it varies from situation to situation. There's no question about that. And sometimes you simply don't need to do a video consult. But it's just been a really interesting experience looking at how I work in the small regional environment compared to how I work in a metro environment.
Thanks.
Yeah, great comments. Yeah.
There's been a comment from Tom Durakathill from British Columbia, Alberta, Canada, saying they use iPads to launch their Telestroke system. So I just thought I'd mention that as an alternate. So thank you. Maybe also a quick comment, and this comes back to how we fund teleconsultation. So if I can get a quick comment, do you get paid for doing a consult from Michael and Chris? And then I'm going to turn over to Rehab for the next part.
In Alberta, yes. I mean, I'm actually funded on I guess a capitation type of model. So as a physician, it's an alternate payment plan, but there are billing codes for various types of teleconsultations if you're billing fee for service. So as a physician, yes, and it's encouraged.
Okay, Chris?
Yeah, so our system basically works as a roster of 23 neurologists. They're all virtual, so they can be anywhere they need to be. And they are all effectively working in a hospital environment. So they're basically doing sessional They get paid as they would any session in a hospital. If they're working out of hours, we have other payment structures for the out of hours consultations. So when they come to work in and do their telemedicine shift, they're basically doing a hospital shift.
And they can do it from anywhere.
They're dedicated to that, yeah.
Yep. Yep. And the beauty of this is they can do their work from anywhere, which is great.
Yeah.
All right. Thank you. Now I'm going to ask Patty actually around other forms, so not in the acute space, but can you give us a sense of, given what you've just been doing around the guidelines about the funding piece, you know, what's happening with post-acute? And I'll also ask Dominique about this as well. So that how do we build a sustainable model for being able to deliver rehabilitation?
And thanks, Julie. And that is a really big issue right now. The occupational therapists in our region who've never had to do virtual consults before and are now doing virtual are getting paid 27 Canadian dollars a consult, which is totally unsustainable and somewhat ridiculous. You know, it probably costs them more to process that fee than actually the money that it's worth. So there's been a major issue outside, you know, reimbursement for physicians and Telestroke has always been a barrier, which is, you know, getting better. But for other therapists, it is a big issue right now because it's never been dealt with before. So across the board, physio, OT, speech, social work are all working with their colleges now, at least in Canada, to try to establish a reasonable fee structure, because otherwise we won't have the sustainability.
Exactly. Thank you, Patty, because it is this big burst of activity right now, but we have to work out ways of making this work. Dominique, do you have comments about that particular aspect?
Yeah, I think it just depends, because we've got a number of pilot projects where they're getting some block funding for a period of time, such as with our tele-neuropsychology program that's only being run in 3 sites at the moment across Victoria. But then there are other services that have been established and they're either being funded through government as dedicated services, or there is a billing mechanism for outpatient visits or that type of rehabilitation service. So it's just a bit hit and miss. And then there are other programs where clinicians like Allied Health are just having to fit it into their usual work. So, and they're not getting any increased capacity. So there are a whole raft of issues that we need to deal with, and that's reflected in how we've set up those interest groups to work on that. And, you know, we're hoping to also learn from the experience of other countries so that we don't, you know, fall into the same, you know, potholes. But at the same time, we also may generate some evidence to support best practice, including in the way in which we remunerate for these types of services, or assess capacity so that services aren't eroded. The inpatient service at the site providing telehealth to a range of patients external to their service, for example, should not be eroded. So that whole issue around some standardised data collection to look at quality of care, to look at adherence to best practice guidelines is really fundamental. And I think that's the way in which we can work with the WSO to, you know, bring that together.
Thank you, Dominique. That's a wonderful place for us to finish. The questions have been answered as we've been going along. We may consider a tweet chat later in response to this. It's a very important and live issue for us all at the moment. I am going to finish the webinar. I want to remind you that this has been recorded and you will be able to access this webinar, this filming, both via, I'm sure, the Canadian Stroke Consortium as well as the WSO. And I'd like to thank all the panellists for participating in today's webinar. So thank you very much for your participation. We hope it's been helpful. Please reach out if you'd like us to do further work in this domain, and goodbye to everybody.